So we have another couple of great talks for the rest of the afternoon. As kind of has been alluded to through the afternoon, interventional radiologists have a reputation for wanting to do procedures and just do procedures. Dr. Bendel here, Dr. Emily Bendel, has been my partner in all of this for years. And I can tell you, out of every procedural person I've met, she is one of the only ones who I can truly say is also a clinician at heart, whether or not she wants to be sometimes. But anyway, so you get the best of both worlds in her. She's going to talk to us about advances in the treatment of vascular anomalies.
Thanks, and thanks for having me. It's really a privilege to be able to be here again. I saw some of you 4 years ago, but it's been a while. Different world here, talking behind our masks. The stuff in this talk, some of it, I was just telling one of my colleagues, even just talking to my family members who kind of know what I do, they really have no idea what they're looking at with this imaging. So don't feel overwhelmed by the radiology pictures in the presentation. It's there, because I don't know how to put together a talk without it, pretty much. And but the point is not necessarily the pictures so much as introducing you to some of the things that have come along the way over the years and are being offered in certain situations for patients like you. There's still a lot that needs to be found out about, does this work in the long term? What happens in the long term? And that's the hard part about innovation, is we might be able to do something, but we may not be able to tell you, what's it going to look like in 10 years. Anyway, so we'll go through some of the innovative treatments that are out there right now, some of the things that are being talked about at my and other society meetings that we attend. A lot of it's not the bread and butter that, you might have heard about in the past. I'm always happy to talk about those things, but I really can't call it a talk on advances unless I show you some of the new stuff. So. All right, there we go. So historically, what we would do, 50 years ago, maybe would be to describe something. We do conservative therapies, which we still do. Surgery, we still do that too. And venography, where we put an IV in, put contrast dye in, take a look at the veins, and take maybe an X-ray, one that you could actually hold in your hands. This one here I came across is in a patient with KT, actually from this exact date, July 22nd, 1987, when we were still doing plain film, hard copy plain film, and you would annotate it with the patient's clinic number, which I blocked out, and you'd write right, and then it'd go into some file somewhere. And we don't do that at all anymore, at least not here. I do know of one place that still does that, actually, in the United States, and probably internationally there are places that still do that. But for today's world in the United States, where everything is digital, basically. And so when you think just back in 1987, we were still doing that, all the way to today with some of the technology and imaging we have, it's really incredible, like how far it's come. And it's only going to get more and more amazing, as we've even seen in the last decade. So, this is a paper from 2018 by Dr. Glavitsky and Dr. Bjarnason. And this is where they surgically resected an embryonic vein in a patient. And so that's only 4 years ago. We're still doing surgery. Those options are still out there, but for a lot of things nowadays, we try to do it minimally invasive. We're trying to avoid the scars or the prolonged healing times. But I like to break it up into kind of how do we think about it now in terms of prevention? Are there procedures that might help a patient avoid a problem in the future? And do we know what those are? And then problem focused, which are, we've got an issue. What can we do? What procedure might help with this issue, if there is one? And should we combine it with other therapies, medications, etc.? This is a child, just an example. somebody comes to be seen in a malformation clinic and you're asking yourself, they have no issues right now. They're living their best life, but they do have some extra veins. They do have an embryonic vein. They've got a capillary malformation. They've got the start of some overgrowth, but maybe not enough to influence, a lift or any procedure right now. But what should we start thinking about? And that's where we're still in the early stages of guessing, what's really going to have great long-term outcomes for a child or an infant that's born with KT. So the problem focus, you guys are all very familiar with pain. You can have bleeding, and bleeding may not just be from the skin. It could be rectal, vaginal, urinary, extremity pain, superficial thrombophlebitis or clotting in the superficial veins, cellulitis, lymphedema, ulcers, DVT, PE, over or undergrowth. And we see these things not uncommonly. Here's a venogram showing the extensive number of veins in this leg. And here's the ulcer that's formed due to that venous hypertension or pressure inside the veins and just not emptying right. So in this patient, to be a candidate for some sclerotherapy or perforator ablation, but in combination with our conservative therapies like compression, elevation, and maybe some topical medications as well. Prevention focus. This is always kind of a controversial topic because it's really only come out in the last decade, where we've started recommending things, even if people aren't having issues, such as a marginal vein ablation or embolization, or maybe if there's an extensive burden of vascular malformation early on in life, we start asking the question, maybe if we do something today, they won't have this problem tomorrow. And then there's preconception planning too, for people that maybe want to get pregnant and they're already have these veins and suspecting they might get worse. Is there something we should treat now? We always have to remember that no procedure is without risk. So if we're going to, do a procedure in the hopes of making somebody better down the road, we certainly don't want to make them worse, but we can't eliminate all that risk together, or all that risk. Here's an example from 2022. So just this year in the Journal of Vascular Surgery, Venous and Lymphatic Disorders, options in the treatment of superficial and deep venous disease in patients with Klippel-Trenaunay syndrome. And they looked at 30 or so patients. Of those, at least 10, which is kind of a low percentage, had a lateral marginal vein or embryonic vein. And here are some of the commonly incompetent veins: GSV, SSV, popliteal vein, and then talking about the procedures that can be offered. So this is still getting publications on these interventions and what's working and what's not working. Preventive measures. This is a infant who we treated the lateral marginal vein. You can see on the side here, this vein very small coming up. But the idea being, if we can treat that at a young age before they're growing, before it can get to a really large size that's much harder to remove, either with, or may require a surgery to remove it. As you know, we can find veins anywhere. So arms, legs, pelvis, you name it, you can find it anywhere. But before we do a procedure, we really have to think about, what's going on with that extremity or with the pelvis. Does that limb have a competent deep venous system? Like, do the valves work in that leg? What's going to happen when we remove these veins or treat these veins? And if not, is it worth risking some increased swelling to treat this other problem? Is the problem focal in one place, or is it everywhere? What is the extent of the varicosities and the relationship to the deep veins? If we inject a chemical into some veins, is it going to go right into the deep veins and cause a clot, or is it going to stay there and work? What types of chemicals should we use? And there's a lot of controversy over that. What prior procedures has the person had? Is their DVT actively ongoing, or SVT, so clot in the deep or superficial veins? Are they going to need an IVC filter? And if so, what's the size of their inferior vena cava? Would it even accommodate an IVC filter? Is there extension into the joint spaces or into the bone? That can be very hard to treat. And then is there involvement of the organs like the spleen we commonly see? So here are some examples of all the different places. So this is inside the bladder wall. This is a large embryonic vein traveling through the sciatic notch here. And here's an example of venous malformation in the vaginal wall and cervix. The presence of deep veins, we used to just do the venogram like I showed you from that 1987 x-ray. Nowadays we have MRI, we also have ultrasound, we have CT, we have a lot of ways to evaluate it. But sometimes we still need to do a venogram. So here's the example of a 3D reconstruction of the huge lateral marginal vein running along the outside of the leg here. And you really can't tell, there's so many veins in this leg, if there's a deep system. The venogram, you can put rubber bands, tourniquets around the leg, and now you can see there are in fact deep veins in this patient. They run all the way up. We use all kinds of imaging. Ultrasound helps give us a map of where those veins are. CT might help us to see phleboliths or where there's been clot that's calcified, where the distribution is. And then it'll tell us, is it all veins? Is it lymphatic? Is it arterial, which we rarely see, but it is something we have to consider. The MRI is really taken over as a way to reduce radiation, since a lot of times we have to image many times, and also show us different features. So it can show the dilated vessels, the embryonic veins, all the bony involvement. And then it also can help with dynamic imaging. So real time, they inject contrast and we can watch it over time as it fills out those veins or as it fills out the arteries. We never had that, 30, 40 years ago. Of course, you may have to lay in an MRI scanner for like 3 to 4 hours sometimes, which everybody knows is not that fun. So here's an example of one of those real-time sequences where you can see that the arteries here fill on the right leg, but by the left leg, it's already made it all the way around to the veins that are filling there. And that's all under real time. So what kind of procedural options do we have? Well, sclerotherapy, many of you are probably familiar with that idea of injecting chemicals. We have alcohol, sotradecol, bleomycin, polydocanol foam. This year at my society meeting, there was a really nice abstract on treating lymphatic malformations using polydocanol. Well, we actually don't have that available to us in this country. So it's nice, but it's not something we can readily get a hold of. So we're, using what we have, and then also kind of following along to see what works. Phlebectomy, where we actually pull out the veins, embolization, where we plug things up. And then there's thermal ablation or cryoablation, where we either freeze or burn tissue. There's also image guided ablation, and I'll talk about the difference in those two things. Filters, and then surgical resection, we don't ever want to forget about. And then the dermatologic, which you saw in Dr. Anderson's talk a little bit about. So marginal vein occlusion or embryonic vein occlusion, this comes up quite often since 60 to 80% of people might have embryonic vein with KT. And here's an example of a child where had a lot of leg swelling, went to treat it. This is the radio frequency or laser, and we burned the vein. And you can see this map showing the vein running along the outside of the foot. Well, it opened back up again. She had relief for a little while and then it opened back up again. So then we went back and we used coils and some alcohol to shut this down. And then the next time she came back, it was completely gone. So sometimes we have to use different techniques depending on the patient. Here's an example in the chest. You can see the capillary malformation of the chest wall. There's veins underneath it, but there's this embryonic vein running up the inside of the chest wall here that measures up to about 14 millimeters. This person was interested in getting pregnant and worried about DVT and PE. we elected to go treat this and treat some of the venous malformation as well. The first thing was to prove that we weren't going to do anything to the blood flow out of the arm. So we did a venogram of the cephalic vein. You can see the big marginal vein running up here along the inside of the chest. We placed these coils in there and some glue to scar it down and hold it in place. And then behind it, we did sclerotherapy of all these veins in the chest wall. And that was closed on follow-up CT. Sometimes, though, the veins are already too big to a point where heat or some sort of minimally invasive technique will work. This is a patient with veins that measured up to 3 centimeters in size in a leg where it was fairly noticeable. So we can go in there and plug it up and put a bunch of clot in there, but this person's going to feel that for a very long time if it ever goes away. So this person went and had it surgically resected. There were some bigger incisions with that, but they had a very nice result. So there are some limits of minimally invasive treatments, and that's why we work together. Sclerotherapy is where we stick a needle into the venous malformation or lymphatic malformation. Here's one in an arm. And we inject contrast to see what the flow is like. And then we inject our agents. It could be alcohol, so Tridecal, or bleomycin. Bleomycin is the one that's come on in the last decade or 15 years that's been a little controversial about if it helps. It's typically used for other applications, but it's really not injuring. So alcohol has a really high rate of injury. A lot of people can get wounds. They can get nerve damage. Bleomycin we tend not to see with those same things. It's not a lot of swelling, but it still can be used in areas like the forearm or the feet because it's not as likely to injure the nerves. You do have a lifetime risk or a lifetime dose, of how much you can use. But you see in this meta-analysis, it actually does show good size reduction reported in 84% of lymphatic and 87% of venous malformations. However, of the ones that are treated, generally you need multiple treatments. So this expectation that I'm going to go have sclerotherapy and it'll go away. Well, if you look at this study that just came out in 2021 in children with Klippel-Trenaunay, most of them actually needed on average 4 sessions. And this was a small series, which we usually see small series in children, but one of them even required, or 2 required 7 treatments to really get that improvement, both on the imaging, but also clinically. You can imagine going back for a procedure 7 times might, have its own inconveniences. All right, we'll just skip the embolization. Image-guided ablation. This is really a new application of an older technology. And we just presented, my colleague, Dr. Thompson, at the ISFA meeting this year, some of our results. And it's exciting because it gives us another option in certain situations. Here's an example of a kidney tumor and these probes going into it. And that was the old application, or still they use it today. But for vascular malformations now, we can use this same to treat an area of malformation that maybe is not responding to sclerotherapy. We have laser ablation, cryoablation. We typically do it under MRI guidance. This is what it looked like before in a foot with a venous malformation. And we put the needles in and the contrast dye, and it goes throughout those channels. Cryoablation is a little different because we put the probes in and then it basically freezes or burns an entire area. So more like a sphere or an ellipse of tissue. So it really gets at the tissue in addition to working with the veins and damaging the veins. Here's a paper that we published in the Journal of Vascular Anomalies. Dr. Kepsel and Dr. Thompson do a lot of the MR ablation. And this was 5 patients with foot vascular anomalies that had this, and they had decreased pain and improvement and ability to return to active lifestyle. This is all pretty new. This is all, happening within the last decade. So we still don't really know those long-term results. Here, though, you can see this patient had an ablation of this area here in the hip. And this is what it looked like right after they treated it. And then 3 years later, you can see it's much smaller here. And their pain went from at worst a 9 down to a 0 at 3 years. So that's pretty good long-term follow-up. But we still want to know, is it going to come back? Because that's what happens. A lot of times people have sclerotherapy at house, but oh, now this area, is bad, or that area is bad. So, that's the appeal of surgery, is we can sometimes get rid of more of something, but even with that, it can come back. So we want to know, like, how long is this going to last? But it's more than just looking at the imaging or the MRI. For most people, it's really looking at, what do people experience? So Dr. Thompson actually presented the outcomes following percutaneous MRI guided laser ablation and cryoablation of vascular anomalies for 12-month outcomes at ISFA this year. And the results were pretty good. Shows that there's early significant improvements in both pain severity and pain interference outcomes with vascular anomalies in the soft tissue. Now, these are pretty localized malformations, not as extensive, but for certain areas, it can be very useful. And so we'll have to keep following. But that's doing surveys, questionnaires to see, how was your pain before? How was your pain afterwards? Now, a lot of our attention is kind of focused on the veins. We don't want to forget about the lymphatics. It's really easy to forget about the lymphatics because there's not usually a lot we can do about it aside from compression. However, there are a small group of us that are quite passionate about the lymphatics and are constantly trying to learn as much as we can about it. And so just to introduce you to some of the newer technology, if you don't remember, the lymphatics are kind of like the body's mop system, collects all that fluid. A lot of times we can evaluate it using the lymphoscintigraphy, which is the gold standard for lymphedema, is to do that test. And if you see it all backing up, say, oh, there's lymphedema there. And many of you may have had that test. You can also do a standard lymphangiogram where you introduce a dye through a cut on the top of the foot and you follow it up the leg. And that's another way of studying the lymphatics. But in this last year or two, we've been able to actually develop a technique where we can use dilute gadolinium inside an MRI scanner. We inject it into the feet just like the lymphoscintigraphy. So no cuts or anything. And then we can follow it real time as that gadolinium is taken up by the lymphatics and see where it goes. So this is a child with cloves who had a debulking surgery and ended up with a lymphatic leak and a drain that couldn't come out because it kept pooling. So we were able to use this technique to see where that point of leakage was. So there's going to be other applications for this technology. We're still in the kind of learning about the technique and who's the right patient for that technique at this point. But I suspect that as we go down the road, we'll be using it for more and more, and maybe to anticipate who would be a good candidate for a lymphovenous bypass, or what do we need to watch out for with debulking in the setting of lymphedema, looking at the distribution of the lymphatics. We do other procedures, namely sclerotherapy or embolization in the setting of preoperative, like for a knee replacement. People get older and it's not that they just have KT, they also have degenerative changes, but now nobody wants to operate because there's all these veins there. So sometimes we will help get them set up for that surgery, usually at a bigger center where they can maybe handle a little more bleeding or have techniques for that. But that's something that we also can do as part of interventional radiology. We don't just do extremities. We treat a lot of patients that have very painful pelvic swelling. That's usually labial swelling or veins kind of around the area of, the butt, and they will come wanting some relief. I can't ride a bicycle, I can't do this. So we'll do some sclerotherapy there as well. Here's an example of phleboliths at the elbow that was quite painful for a patient. We were able to just make a tiny little incision and pull that out while at the same time as doing sclerotherapy. And that begs the question, what kind of prevention can we do to prevent people from getting those painful phleboliths? And, that's something we're still learning about. And vascular medicine has been helping us with identifying those patients that maybe need to be on a low dose blood thinner or, aspirin to help prevent developing as many of these painful phleboliths and catching them before there's so many that we can't really do much about it. And there's the little, so it's a piece of clot that then over time it sits in the vein and turns into calcium, like a little rock. So we call it a phlebolith. Lith is like stone. Phlebo meaning like vascular or related to like the clot there. So it's just a clot that turns to stone. And people get them anyways, in their pelvis, anywhere veins just sit around and clot. But that tends to happen more when you have more veins that don't flow as fast. So usually you can feel like a little hard rock under your skin. And for most people, it doesn't bother them that much. But for some people, it's right in an awkward location, like at the elbow or maybe a pant line where you bend your knee on the foot. It's very common, and if that happens, it depends on the location, but sometimes it can either be surgically removed or kind of, if it's really superficial, as this one was, kind of popped out at the same time as doing other procedures on the veins. Okay, another new therapy is called Claravane. This is a kind of like a whisk that is inside the vein and stirs up the foam chemical agent sotradecol that we also use for sclerotherapy. And this, if you think about a marginal vein being a giant tube in line, which it often is not, unfortunately, but occasionally it can happen even in the arm, or like I showed you an example in the chest. And this is a technique that we used in this arm because sometimes using heat can cause nerve damage. There's a lot of nerves in the arm. And so we were able to get into this vein. That's that dark structure here. You can see the marginal vein or embryonic vein in the forearm here. We're able to use that technique where it stirs up the foam and causes the vein to spasm. And then that was gone at the next evaluation. So just thinking outside the box, areas where the skin's really thin and we can't use a lot of heat because we might burn the skin, trying to use some other things and tools. So this glue embolization followed by surgical resection. This is a paper actually written by Dr. Polides, who's here, and she wrote up this technique of resecting malformations after putting in a type of glue. It's called cyanoacrylate. It's actually just Gorilla Glue, but sterile and much more expensive. So unfortunately, I wish I could just run down to Menards and get some, but as of right now, that's not allowed. So, but what we do is we inject that into one area and then surgeons are able to resect it potentially more completely because the glue goes through smaller channels that maybe you don't see at the time of surgery. Correct me if I'm wrong, but so that's also something. Here's an example of a small venous malformation, put glue into it, then was able to be resected. 1 month later, the patient was doing much better with her pain symptoms. So, all right, I think I'm almost done here. So through all of this, we don't want to do a procedure just to do a procedure. We're constantly thinking about the risk versus benefit, and it really comes down to the individual person. Even though, we look through the literature, we try to create these algorithms for ourselves. If this, then we're going to do that. But almost nobody reads the book, and when it comes to KT, that's definitely true. We see people with all different presentations, and what works for one person doesn't necessarily work for the other people. That's the advantage of having a big experience, though, seeing a lot of patients or having a doctor that's seen patients with something that you've had, is that they have seen maybe what works in your type of situation, or at least has a toolbox of a few things we could try for that problem, or they know who to call if you want to try something else that's not a procedure. So when I'm doing these, I'm always thinking about, could we damage a nerve? Could we run into bleeding? Could I cause clot, or am I trying to get rid of clot? Skin breakdown, ulceration, and what that would be like for that patient in that area. And then just the timing of things. People have lives. They don't always, can't always do it at that moment in time. How do we not lose somebody to follow up and they miss out on an opportunity for this procedure, and working with people for that? So moving forward, there's a lot we need to do research wise. Medication delivery, a lot of these medications that are coming out orally, maybe we can give them more locally instead of having to take a pill. Maybe we could deliver it in a different way. Correlating with genetics, and then looking at these quality of life or brief pain inventory assessments. This is the one from Dr. Thompson's study. Sorry, it's so small, I can't even read it here, but showing the walking ability gets better, the pain gets better, the pain relief gets better over here, sleep, getting fewer disruptions in sleep. So really looking at, patient experience from these procedures, and not just, oh, well, in the MRI, it looks like it's gone. Well, yeah, but the patient still had pain. So can we really call that a success? And collaborating between other groups, registries, to help build our numbers in the literature. So it's not just looking at 6 patients, but maybe 100 patients, which has a lot more power. And then always considering our multidisciplinary approach, and not forgetting that it's not just about the procedures. It's really about, what is going to be the best thing for this patient that's in front of you. So thank you.